Hello dear students, hope I'm audible. Just let me check whether audio video if everything is clear or not. Hello, good afternoon everybody. How are you people? So last time we are sorry for the inconvenience what happened because there was a sudden heavy rainfalls happened in Bangalore, because of which what happened was there was a power cut and there was other issues also. So that's why we had to stop that session. So we'll continue from where we left off earlier. Okay, just let me check that audio. Okay, perfect. Okay, so good evening, good afternoon, sorry, good afternoon. How are you people? So the thing about today's discussion is very simple. What we are going to do is we are going to learn radiological aspect. We were studying about chest x-ray. So chest x-ray, as I taught you people earlier, there are three things which you must always look at. That is angles, both sides angles. That is your CP angle. That is only called as costophrenic angle. And also we are supposed to look at the bronchovascular markings and as well as your what is that cardiac borders. That will give you a lot of idea. Apart from that, there are other things such as you need to look at the lung parenchyma. I agree with that, but main three things are for our exam point of view I had taught you people, right? So now, Ashka session, what we are going to do? So, we are going to learn about hydrothorax. Hydrothorax means what is that? Fluid inside a chest cavity. So, fluid inside a chest cavity, as I already discussed, whenever a radiological image is given, first determine which side. So, this is going to be your left side, this is going to be your right side. And I told you people A, B, C, three things you must look for your exam point of view. That is your, what is that? Angles. So, if you look here in this area, the angle is blunt, my dear students. Which side? On the left side, the angle is blunt. So, if the angle is blunt, that is suggesting me that there is a fluid accumulation and this area fully filled with fluid. So if there is a fluid accumulation in the thoracic cavity, what can be the cause for it? The causes, my dear students, that can be due to hemothorax, pleural effusion and emphysema. So what are the differences between three things? So hemothorax is the condition when there is, what is that? Yes, trauma to the chest. If there is a trauma to the chest, blood vessel is going to rupture. If the blood vessels are ruptured, the bleeding will occur and all the blood will start to accumulate in the chest cavity, leading to something called as hemothorax. So hemothorax and pleural effusion, that can occur as a result of accumulation of fluid. That can be due to some pus accumulation or some fluid accumulation. So that is called as pleural effusion. Emphysema, a large amount of pus accumulation in the thoracic cavity. We call it as, what is that? Yes, very importantly called as a emphysema. So now in this condition, what we are supposed to consider, it is called as hydrothorax. So hydrothorax can be due to pleural effusion. Pleural effusion means accumulation of fluid in the thoracic cavity. What is that? Accumulation of what in the cavity? Fluid in the thoracic cavity. So that can happen as a result of any systemic disease or the lung disease. What are those? I'll tell you people. Just listen to me. Pleural effusion, which is also called as pleurisy. So pleurisy will occur as a result of this particularly. What is that? That is your, very importantly, exudative pleural effusion or a transudative pleural effusion. So what is a exudative and a transudative? So exudative pleural effusion, usually a pus-like accumulation is present. What is present? A pus-like accumulation. But transudative, usually a clear fluid, fluid is accumulated. Exudative pleural effusion, it can be unilateral, means one lung can be affected, or it can be bilateral. It can be unilateral or bilateral. But when we are speaking of transudative pleural effusion is always, my dear students, remember it is a bilateral thing. Bilateral means both sides of the lung will be affected. And the next important aspect, what can cause this exudative pleural effusion is usually diseases of the lung itself. So lung cancer or your pulmonary TB can lead to exudative pleural effusion, while systemic diseases like congestive cardiac failure or chronic liver disease or pancreatitis and nephrotic syndrome can lead to your transudative pleural effusion, where there is a clear fluid accumulation is present. A clear fluid is being accumulated. Okay, so please understand, to differentiate between whether it is a transudative pleural effusion or exudative pleural effusion. So remember, we use a criteria called as a Light's criteria. What is that called as? A Light's criteria. What is that called as? A Light's criteria. Light's criteria is used for what is that? To differentiate between the transudative and exudative. So how do we use this criteria? Remember, what we are going to do is that we will take the pleural fluid, my dear students. What we will take? Pleural fluid. We will take out the pleural fluid. After taking the pleural fluid, we will run some tests such as that is your LDL levels, LDH levels, for example, glucose level, other values are there. So based on using those values, we can calculate whether it is a transitive or a exudative pleural effusion. So let's look at this one. So let's look at this image, but before going there, let's look at the clinical features associated with what is a hydrothorax. Usually pleural effusion, so that is your dry cough will be present. Why? Because the fluid which has accumulated around the thoracic cavity, in the thoracic cavity, that will lead to irritation and create the cough, and the patient will have a chest pain. Now you are going to get confused, sir, how to differentiate whether it is an anginal chest pain or a other type of chest pain. Remember, anginal chest pain is usually a diffuse chest pain. Usually it's what type of chest pain? Diffuse chest pain. But when we are speaking of pleural effusion, it is a type of pleuritic chest pain. We'll call it as what is a pleuritic chest pain. Means patient will point out, sir, here only I'm having pain. Here only I'm having pain. So he will be able to point the pain. So if the patient is able to point out the location of the pain, then we'll call it as a pleuritic chest pain, and in X-ray we will have a blunt of CP angle. Okay, so let's look at this one. So in this image, first it is which image? It is the radiological investigation used is X-ray. Okay, radiological investigation used is X-ray. So in the X-ray investigation, what else we need to understand? The next question you are going to have, it is a investigation is X-ray, and the next important aspect you need to look here, my dear students, what is there is your which type of view. So usually it is a PA view. Why it is a PA view? How did I come to this conclusion? So I told you people, for the lung, all other lung diseases, usually we use PA view only, except for trauma or shoulder joint related issues. Only that time we are going to use a AP view X-ray. Because what is the reason? Yes, come on, tell me what is the reason? Yes, the reason is very simple, because it will make the heart to look bigger if you use a AP view. That can make us confused with a cardiomegaly. So as I told you people, here in this chest X-ray, if you can notice, on one side the angle is totally normal, but here if you notice, there is a blunting of the angle. There is a blunting of which angle? Costophrenic angle, which is also called as CP angle, not place angle. It is called as costophrenic angle. What is that? Costophrenic angle. So costophrenic angle, what is there? Blunting is there. Okay, and apart from that, the next important aspect, bronchovascular marking. Let's zoom in and see. So inside this, yes, there are small lines which is suggesting me of what is that? Bronchovascular markings are present. So these bronchovascular markings, if they are there, that means lung parenchyma is fine. So this is the story of your what is that? Yes, hydrothorax, which can be caused by pleural effusion, or it can be caused as a result of trauma. Okay, let's go to the next important condition called as a hydropneumothorax. First and most important, usually the cause is trauma, my dear student. Usually it is caused as a result of what? Trauma. Okay, now if there is a trauma is the cause, what can happen? I told you people here, hydro means fluid, pneumo means air is present. So how do we understand? First and most important thing, look here, if you look at this image, now here, so let's zoom in and see on the left side. Yes, this is your left side. On the left side, if you notice here, in this particular area, is there any bronchovascular markings? No, no markings. No bronchovascular markings. There is no markings. If there are no markings, what is suggesting me what has happened? Yes, air has entered and it has collapsed the lung. So air, there is a trauma to the chest. Because of that, what came into the chest? Air came into the chest. Because of what? Because of that, what has happened is collapsing of the lung. And also see, if there is a trauma, there is no rule that always only what can happen? Only there can be air. No, there is no rule like that. There can also rupture the blood vessel, that will create a bleeding. So if there is a bleeding, then it is telling me what is that? It is a hydropneumothorax. And most importantly, there will be a clear cut differentiating line. So this is the most important highlight key point which you must remember. A clear line is present between, here is the air, yes, here is the fluid, yes. Between the air and fluid, what is present, my dear students? A clear differentiator line will be present. Sir, how does this line come? So when they have trauma, they will put one line or what? No, listen to me. It's very simple senses like this. Consider this is one water bottle, right? So in the bottom part, I have water, right? In the up part, it is empty. Is it empty? Think logically. We are the medical students. Yes, it is not empty. It is filled with what? Air. Very good. So you can notice there is one clear line that is above this air is there, below this water is there. Like that only we are trying to differentiate. Whatever I am trying to tell you is below is the water, above is the air, and there is a clear cut line we can appreciate. That is only called as this clear cut line we can appreciate, right? So we are understanding below is the air, above is, below is the water, above is the air. So like that only what we are having is your, what is that? That is your clear cut line which is present between, what is that? Present between your, yes, that is your air and the fluid. So we will call it as, what is that? We will call it as media, sorry, we'll call it as a clear line called as hydropneumothorax. So hydropneumothorax will occur. It will compress the lung. It will push the all the mediastinum to the opposite and healthy side, So this is what is your, what is that, my dear students? That is your, yes, very importantly, mediastinal shift will be present. Okay, let's go to the next important. So this is accumulation of air below the skin. So here you can notice this as just air accumulation present below the skin. We would call this as, what is that called as? Very importantly, surgical emphysema. Surgical emphysema, which is also called as subcutaneous emphysema. Subcutaneous emphysema. So subcutaneous emphysema is a pathognomonic sign of a disease called as Boerhaave syndrome, So please understand, Boerhaave syndrome is a spontaneous esophageal rupture. What will happen? Esophageal rupture will occur. So why this esophageal rupture will occur? The esophageal rupture will occur as a result of vomiting, right? Now you can ask me, sir, even I have vomited when I was child because of some food poisoning or something. Did I get Boerhaave syndrome? See, understand, a person who has alcohol, okay, elderly person who drinks alcohol and suddenly vomits. The point here is not about drinking alcohol alone. The most important point, after drinking alcohol, sudden vomiting will be there. What is it? Sudden vomiting will be there. That is only called as forced vomiting, create a esophageal rupture. So if there is a spontaneous esophageal rupture, we will have a syndrome called as Boerhaave syndrome. So in the Boerhaave syndrome, you are going to get something called as Mackler's triad. What is that called as? Mackler's triad. Okay, so what is this Mackler's triad, sir? This was a previously asked MCQ. Please remember, the Mackler's triad occurs as a result of Boerhaave syndrome, which will have vomiting. The patient will have vomiting. Yes, of course, chest pain. Patient will have chest pain, a very severe chest pain. Why? Because the esophagus is where? It is in the posterior mediastinum. Where is the esophagus located anatomically? Posterior esophagus. So if it is located in the posterior esophagus, when esophagus gets ruptured, क्या हो जाएगा? फट जाएगा तो क्या होगा? पूरे content leak हो जाएगा. I mean to say, what is that? Leakage of all the esophageal vomiting content. Very simple, as the person is trying to vomit, but he is not able to send all the content out. Suddenly intraesophageal pressure rises, so that will rupture the esophagus. Now all the content will leak into the mediastinum, leading to mediastinitis. Leading to what it is? Mediastinitis. So patient will have chest pain, vomiting, and also surgical emphysema. So this is your Mackler's triad. It is classically seen with a Boerhaave syndrome, and pathognomonic sign is surgical emphysema in Boerhaave syndrome. Clear? So this is a story of your, what is that? Surgical emphysema. Okay, so let's go to the next important condition, congenital diaphragmatic hernia. So what is this congenital diaphragmatic hernia? How it becomes important in radiology? Let's see, right? So normally what is you have your both the lungs like this. Normally we have two lungs which are sitting like this. Yes, of course. Okay, so if both the lungs are sitting like this, and below that we have something called as diaphragm. Below that there is a diaphragm. Here all you have is intestine. Right? Very good. So in the abdominal cavity, what is there? Intestines are there. In the thoracic cavity, lungs are there. Just let's imagine a part of the lung is not developed very well. It is not developed very well. If it not developed very well, all the intestinal content can come into the thorax. Intestines can come into the thorax. Intestine can come into the thorax. So that is only called as congenital diaphragmatic hernia. So if intestines come into the thorax, sir, what will happen? Let's imagine about this condition also. So let's solve this problem by doing very simple. So all the intestinal loops came into, where is that? Yes, that is into the chest cavity. Now this is a congenital condition. If it is a congenital condition, during the development of the baby itself, this scenario will occur. Now what will happen? It will press one lung completely. It will compress one lung because the lung cannot expand or grow properly. If lung cannot grow properly, the lung will remain small and all the intestinal loops will come into the thoracic cavity. So what is that? There is no development, improper development of one dome of the diaphragm. All the intestinal loops come into the thorax. So what is going to happen on one side, whichever the side the intestinal loops have come, all these intestinal loops will compress your lung, leading to what is that? Pulmonary hypoplasia. That is the most dangerous complication, which is a previously asked question. The dangerous complication caused by what? A complication caused by congenital diaphragmatic hernia is the pulmonary means lung hypoplasia. So radiologically the image would look like this. If you can notice here, all this area thoracic cavity is filled with what? If notice here, yes, all of them are intestinal loops. All the intestinal loops which are located where? Located in the thoracic cavity. So which is only called as pulmonary hypoplasia and a congenital diaphragmatic hernia. So if the patient is having a congenital diaphragmatic hernia, the question we will encounter, my dear students, in these patients, remember, positive pressure ventilation is contraindicated. It is contraindicated. Positive pressure ventilation such as, yes, bag and mask ventilation also. You might think, sir, immediately after the birth oxygen is very important, so we will put a mask and we will start to pump the air. Bag and mask we can think, but no, bag and mask is contraindicated, even through the ventilator also contraindicated. Okay, we cannot put him on the ventilator because one lung is not developed. If you send the air forcefully inside, what will happen? It will damage or rupture the part of a lung. So that is why we are supposed to avoid what is that? Positive pressure ventilation. So then what we are supposed to do? So for oxygenation, we use a very important called as ECMO. What is that called as? ECMO. What is ECMO? ECMO is nothing but extracorporeal membrane oxygenation. Basically, outside there will be machine. There will be Doraemon Shinchan. Yes, video will be available. Yes, of course. Okay. So no, listen to me. अरे यार क्या नाम रखे हो? डोरेमोन शिनचैन. चलो, ECMO means extracorporeal membrane oxygenation. What is this extracorporeal membrane oxygenation? Externally we have a machine that will provide, that will basically, all of you would have seen your dialysis, right? So dialysis machine, from one side blood will be coming out continuously, that will filter all the waste product and will put the blood back into the patient, right? The same way what we are supposed to do is we are supposed to give the oxygenation using an artificial machine that is called as ECMO. So let's talk about X-rays in the GIT. Very important ones. What is these important ones? Let's understand the first and most important basics here, my dear students. So let's go back to a chest X-ray. Let's use one chest X-ray and understand. So if you look at a chest X-ray, whenever you look at any chest X-ray, right? You take any chest X-ray, for example, here, so you know that the lungs are ending here, lungs are sitting on a diaphragm, right? Lungs are sitting on a diaphragm. So if lungs are sitting on a diaphragm, now we need to look, my dear students, sorry, this is left, this is okay. So lungs are sitting on a diaphragm. So if lungs are sitting on a diaphragm, below that, what will be there? Anatomically speaking, your esophagus is coming like this. Yes. It will pass the diaphragm, and below the esophagus you have, what is that? Stomach. So we know that anatomically stomach is located just below the diaphragm. So it's very simple. In the right side you have your liver. Okay, here you have your stomach. So the stomach is usually filled with air. Usually little bit air will be there. So because of which a small air bubble we can see below the left dome of diaphragm. Below the left dome of diaphragm, but below the right dome of diaphragm you don't see anything because a solid organ liver is present there. So remember, now in a normal condition there is no air on the under the diaphragm. Which side? On the right side, no air, no air under the diaphragm, but on the left side air will be present normally. That is as a result of gastric bubble, gastric bubble. So now what happens if there is an obstruction of gastric outlet? Let's understand, right? So when we are speaking of obstruction of gastric outlet, very simple. Consider this is one. What is that? Yes, stomach, esophagus, and your duodenum, right? Now what will happen? Let's imagine this is a pyloric part of the stomach. This pyloric part of the stomach has undergone hypertrophy, right? If hypertrophy has occurred, so what will happen? Gastric outlet has been obstructed, so the content from the stomach will not move. All the content will remain here only. The stomach will start to enlarge, stomach will start to enlarge, and more air will fill inside, creating a bubble like appearance. So if you can notice here, yes, we are finding one bubble called as a single bubble sign. We'll call it as a single bubble sign. So very important, frequently asked question. Single bubble sign is seen with what? One is there, goo. Goo means you don't go there. That is your gastric outlet obstruction. Gastric outlet obstruction, and also it can be caused as a result of CHPS. What is this CHPS? Called as congenital hypertrophic. What is that? Yes, congenital hypertrophic pyloric stenosis. Pyloric stenosis. Congenital hypertrophic pyloric stenosis will also create a single bubble appearance. So the best position for an abdominal X-ray, the always preferred position is erect position. That is a standing position. Okay. Then we have one more image here. What is that? So we'll call it as a coarctation of aorta. What will be there? Remember, so notching of the ribs, ribs notching will be there. Along with that, below the ribs, if they give you a image which is zoomed in very much onto the ribs, if you notice small ulceration is present below the ribs. The small ulceration is present below the ribs. The small ulcerations present below the ribs is direct suggestive of coarctation of aorta. We call it also as a rib notching. Okay. All right. So if there is an intestinal obstruction, what will be there? So if there is an intestinal obstruction, we will have multiple bubble sign. Intestinal obstruction, we will have multiple bubble sign, but a better term, remember, called as multiple air fluid levels. What is that? Multiple air fluid levels. Air fluid levels. So when we speak of multiple air fluid levels, so why it occurs? As a result of usually small intestinal obstruction. So if you notice multiple areas, there will be bubbles formation. So in this also, if you zoom in and see, if you consider this bubble, if you notice here, small fluid is present, yes, and here dark suggestive of air. So air and fluid, multiple areas if it is present, it is suggestive of what is that? Suggestive of, very importantly, what is that? That is your multiple air fluid levels, the suggestive of very important condition. What is that? That is your small intestinal obstruction. So apart from the small intestinal obstruction, let's continue to the next important aspect. There is one more sign called as a double bubble sign. What is that called as? Double bubble sign. What is that called as? Double bubble sign. So double bubble sign is always seen with which disease? Double bubble sign is seen with the, yes, very importantly, duodenal obstruction. So if stomach is obstructed, one bubble. If duodenum is obstructed, two bubbles, because one is stomach will be enlarged, one is duodenum will be enlarged. So creating a double bubble sign. Okay. So let's continue to the next important, barium contrast. What is this barium contrast? Imagine if I take a chest X-ray, will I be able to look at esophagus? No. Will I be able to look at esophagus? But instead of that, if I put a contrast is a radio opaque substance. Remember, that is the most important question. What is that called as? Radiolucent or radio opaque. It is a contrast, usually will be a radio opaque. Now what we are going to use is barium. Now what I will do, I will ask my patient to swallow the barium and take a chest X-ray. I ask my patient to swallow the barium and take a chest X-ray. So if I take a chest X-ray, automatically what I'm going to get, my contrast will look very bright and white color. So showing me the anatomy of wherever the contrast is present. That means what? Let's imagine what is there. This is your stomach. This is your stomach and esophagus. Now what will I do is that I will ask my patient to swallow the contrast. Normally, I'm not able to look at the stomach. Now, once he swallowed the contrast, all the contrast will go into the stomach, and I'm able to see that very clearly. Where is the contrast located? In the stomach. So, all this area will be filled with contrast. So, if I take an image, I look at the contrast and look at the anatomy of the particular area. For example, let's understand this. Sir, if there is a perforation, what will happen? Yes, if there is, let's imagine there is a esophageal perforation. If esophageal perforation and my patient swallow the contrast will start to go outside also. If contrast is start to go outside, that will tell me what is that? Yes, there is a rupture is present. We can think of rupture of esophagus, for example, right? So we have multiple types of barium technique. Nowadays, barium is not that widely used. Earlier, we used the barium as a contrast. Nowadays, we have other contrasts also, which I will talk about in the discussion of contrast in the radiology. So now what we have, please remember, so it is a radio opaque, it will look white in color, used for GIT. We have a technique called as barium swallow. Barium swallow means it is a barium will be in the form of a liquid. I will ask my patient to drink the barium containing solution. Okay, barium solution he drank. Immediately I will take the X-ray. Immediately if I take the X-ray, I can look at the barium which is present inside the esophagus and your what is that? Stomach. So I'll be able to understand what is that anatomy of esophagus. So barium swallow is a solution form used for esophagus imaging of what is that? Esophagus. Okay, now barium meal. So barium meal is used. So we ask the patient to eat the barium containing substance. So that will be used for your stomach and duodenum. What is that? Duodenum. So barium meal follow through is done for small intestine. Barium meal follow through is done for which intestine? Small intestine. Barium enema is used for large intestine. So if you can notice here, we have one normal image of esophagus. So you can notice here the patient has drank the barium. Now barium has gone into the esophagus, and now from the lateral view, earlier I taught you people already, in the lateral view we will be able to look at the esophagus better, so we can use it for the diagnosis of esophageal diseases, right? For example, some area, so there was some cancer or something was there, so contrast will come till here. Below this contrast will not be able to go, will not be able to go down. So I will be able to think of what is that? Think of some growth is present. So that will help me understand. So for example, barium enema, I'm sending the enema and I'm making the image. Barium enema majorly used for large intestine, majoritarily used for large intestine. This is your barium enema image, and this is your barium meal, my dear students. So I ask the patient to swallow the barium, and now I will be able to look here very nicely. You're able to appreciate the stomach. For the both stomach and duodenum, we can consider which the content barium meal. Okay, so let's go to the next important aspect, that is only your breast imaging. But before going to the breast imaging, I would like to discuss with you people about some images which are related to your what is that? Which are related to your GIT only, and also about your what is that? That is your chest cavity. Okay, so just let me get the images. Just 1 second, my dear students. I'm trying to insert the images. So let's discuss the images related to the chest. Then we'll continue to the images related to the abdomen. Okay. So first, till now we created a basic outline how our chest X-ray worked and all this. Now let's understand about the individual diseases. Okay. So why am I doing this? I'm doing this because we will be able to understand. We'll be able to understand the diseases. Along with that, we will be able to practice the radiological images. So I want you people to have this practice of the images right here and right now. So let's do that. Okay. So when we are speaking of radiological images, please understand here. So there is one important point. So that is a chest X-ray. When we are speaking of chest X-ray, so here we have, this is your left side, of course, this is your right side. So whenever a image is given, please look up, please look at the sides, which side and what is the investigation. So if you notice here, what are the things we need to look up? So first and most, this is your hilar region. This is your called as hilar region. What is that called as? Hilar region. So all this area will be your lung. So if you notice, there is one small lines which are present. So bronchovascular markings are present. But in the hilar region, if you notice, sir, there are small enlargements I can notice here. What are these? These small enlargements around the hilum of the lung, that is suggestive of hilar lymphadenopathy. Hilar lymphadenopathy. Okay, what is that called as? Hilar lymphadenopathy. So this hilar lymphadenopathy, my dear students, this is caused as a result of, usually it can occur in the patients with TB. Apart from TB, it can occur in the patients with sarcoidosis. Okay, so multiple reasons the hilar lymph nodes can get enlarged. So in the normal chest X-ray, earlier I showed you, you'll not be able to see the hilar lymph nodes, but when you take a enlarged one, okay, so enlarged ones, then we can see very clearly that is a hilar lymphadenopathy. Then CP angle and the chest border. So what is this CP angle? Notice here, my dear students, very importantly, CP angles here. So CP angles, we are clearly able to see what is that sharp CP angles, postophrenic angle. So that is telling me that there is no abnormality with the abnormality, and cardiac borders also looks within the norm. Okay, and lung parenchyma is also fine. So this is suggestive of hilar lymphadenopathy. Now, once we understood about hilar lymphadenopathy, so my dear students, you notice here, so this particular image, this is your left side, this is your right side. Okay, we know the left and the right side. Now here, my dear students, in this image, if you notice, where is the pathology? Yes, you can notice on the right side, in the upper lobe, there is a changes. So this a particular appearance, we will call it as groove sign. We will call it as, see, look here, there is a groove has formed. We call it as a groove sign. We'll call it as a groove sign. Okay, it is seen in patients with pneumonia. Okay, groove sign. Now let's go to the next important image. So what is this image? Yes, what is happening? You have noticed now very clearly what has happened. All the intestinal loops have come into the chest. All this area, what you are seeing is intestinal loops only. What you are seeing is intestinal loops. All the loops present in the chest cavity, if they are present, then we will call it as a congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Quickly comment, what is contraindicated in this patient? What is contraindicated for this patient? Quickly comment. Let's go to the next important aspect. What is that? So let's look at this image. Can you find any disease or not? Let's see. Okay, so first and most importantly, again, what is the investigation done? Chest X-ray. What is the investigation done? Chest X-ray. Here is your left side, here is your right side. Okay, now if you notice, both the angles are fine. CP angles are totally normal. CP angles are totally normal. But if you notice, if you notice here, so small lines are present. That is telling me what is that? Yes, small lines are suggesting of, very good, you're absolutely correct, Rohit. What is the answer? Yes, positive pressure ventilation is absolutely contraindicated. Okay, so you can see the bronchovascular marking. So totally this is a normal chest X-ray. Okay, let's go to the next one. Wow, very nice image. So first let's determine the side. So this is your left side. Okay, this is your right side. Okay, now on the right side there is a problem. What is the problem? Let's see. So if you notice here in this particular area, there is no bronchovascular marking. If there is no bronchovascular marking, lung is not present. If lung is not present, that has happened as a result of trauma and that got collapsed. So there is a pneumo. There is a pneumo. Pneumo means air. But also if you notice, CP angle on the right side is totally blunt. Yes. So that is suggesting me that hydro. So if I want to confirm hydro and pneumo, both are there. Hydropneumothorax is there. So there is a clear cut differentiator line between the air and the fluid, air and the fluid, right sided hydropneumothorax, right sided hydropneumothorax. If you notice, look here, the heart is going more towards the left side, so that is suggesting me that mediastinal shift is there, mediastinal shift is present. So mediastinal shift is present, right sided hydropneumothorax. Okay. So once we understood about this, let's talk about the next important aspect. What is the next important aspect? So the here, so this is again your left side, this is your right side. First and most important, angles. Let's start with the angles. Both the CP angles are normal. Why? Because look here, both the sides CP angle is very sharp. CP angle is very sharp. So bilateral CP angles are normal. Then let's look at the next important, bronchovascular markings. If you can notice in all this area, yes, there are small bronchovascular markings which are absolutely present. But if I notice on the right side of the lung, in the middle of the lung, there is white color patches appearing, white or grayish color appearance. So this is the suggestive of what is that there is some local inflammation. So because of that, multiple white blood cells, everything will come and inflammation will occur. So we will call this appearance as infiltrate. We will call it as infiltrate. So sir, infiltrate is a sign of which disease? It is a sign of pneumonia usually. So pneumonia will have multiple infiltrates. So multiple infiltrate that can be present in one part area of the lung, or also diffusely that can be present. That will tell you there is a patient is having a pneumonia. So now I told you people, inferior rib notching. Inferior rib notching is what? So if you notice the bottom part of the ribs, they are not even, rather there is one ulceration like this, right? If you notice here also there is small damage. If you notice here also there is small damage. So here also there is small damage. So below the inferior, so inferior part of the rib, the what is there, notching is present, and it is in the inferior rib notching. Inferior rib notching is a sign of, yes, coarctation of aorta, coarctation of aorta, coarctation of aorta. So this is a very important previously asked question. Coarctation of aorta will give you which appearance? Inferior rib notching and ulcer like appearance below the ribs. That is telling you what is that? Inferior rib notching. Let's go to the next important picture. What is the next important one? Let's start with again what is the investigation. So this is your left side, this is your right side, of course. So what is this investigation? This is a chest x-ray. Of course this is a chest x-ray. If this is a chest x-ray, then what we are supposed to look at? Angles. Both the CP angles are sharp. If the angles are sharp, they are normal. So earlier I was telling you people, below the thoracic cavity, so here is your diaphragm, right? Below the diaphragm, can you see some air? Yes sir, air is present. Under which dome of diaphragm? Under the left dome of diaphragm. Under which dome? Left dome of diaphragm. That is suggesting you that is a stomach. That is your stomach. That is only called as gastric air bubble. Gastric bubble under the left dome of diaphragm. But on the right dome, if you can notice below the diaphragm, the solid organ liver is there. So we will not have any clear any air appearances. So once I finish these angles, all the bronchovascular angles are normal. Bronchovascular markings, bronchovascular markings. Let's look at the bronchovascular markings. They are present. So in all over the lung, if you notice, yes, they are present. Okay. Slightly, if you notice, slight enlargement you can find out in the hilar lymph node. See, so this is your heart border. Now here is your enlarged hilar lymph nodes. Okay. Now apart from that, this particular area in the right side, in the upper lobe, you have, if you can notice, there is one area. What has happened here is the air is present, top air is there, below what is there, below there is a fluid, that is why which is looking grayish color. So this is suggesting of air and fluid which is present inside one circle of the lung, suggesting you of what is that, pulmonary abscess, my dear students. So what is that called as a pulmonary abscess. So pulmonary abscess, what will happen? Pulmonary abscess means what will happen? Pus accumulation in one particular area of the lung. Patient will have clinical features such as sputum will be there. Yes, sputum. The sputum will be yellow color. Yes, foul smelling, very bad smelling sputum can be present, and sometimes even pus can be present, and also fever and pain will be there. So these are the clinical features associated with the pulmonary abscess, are also called as a lung abscess. Now for this particular image, I want you people to tell me the diagnosis. Okay, I'll give you a few seconds. What is a diagnosis? You people make the diagnosis and put it in the comments. I'll wait. Come on, tell me. So, what is the diagnosis? Very simple. Let's start with the basics. It is a chest X-ray. Yes, sir. Left side, right side. Yes, sir. On the left side, angle seems angle on the left side. Angle seems abnormal. What is happening to angle here? Yes, the blunting of CP angle. Blunt CP angle. What is that? Blunt CP angle on which side? Very good, on the left side. On the left side, blunt CP angle on the left side is suggesting you of what? Yes, that is suggestive of hydrothorax. What is that? Hydrothorax. Now hydrothorax can have two possible scenarios. That can be due to pleural effusion, that can be due to hemothorax, that can be due to hemothorax. Now the important point, sir, how do we differentiate from pleural effusion to hemothorax? Hemothorax occurs as a result of trauma. Sudden onset will be there, and immediately after the trauma, and also signs of bleeding such as decrease of blood pressure and increase of heart rate can also be present. So this is telling me what is that? It is a type of hydrothorax. Let's go to this image. Let's make the diagnosis of this one. Right. So when you look at this image, my dear students, please look here. What and all is that? First, this is a right side or left side. This is your left side. This is your right side. Okay. Now, first one, angles. Both the angles seem sharp to me. If both angles seem sharp to me, then what is the problem? On the left side, if you notice here, this area is looking at a jet black color. Jet black color means there is no bronchovascular markings. What are they called as? No vascular markings. Sir, if there is no vascular markings, then what does it mean? So if there is no vascular marking, that is telling me what is there? Yes, if there is no vascular marking, and if you notice, mediastinum is also shifting, right-sided mediastinal shift. Yes, mediastinal shift, right-sided mediastinal shift can be present. Apart from the right-sided mediastinal shift, what else is there? What else is noticeable in this image? So if you notice, on the left side, there is no vascular marking, that is creating a jet black appearance, jet black color on the left side. So these are suggesting me of what is that? The most important radiological sign is no vascular marking. If there is no vascular marking, that can occur as a result of pneumothorax. What is that? Pneumothorax. What is this pneumothorax? As a result of trauma, penetrating trauma. Basically, majority of the time, this occurs as a result of penetrating trauma to the chest. Penetrating trauma to the chest. So whenever there is a penetrating trauma to the chest, what will happen? Let's see. Consider this is your chest wall. Consider this is your chest cavity. Okay, inside the chest cavity, you have both the lungs sitting like this. You have your both the lungs which are sitting like this, right? So above the lungs, we have one layer called as pleura. That is a double layered. One is just next to the lung, that is called as parietal and visceral pleura. Visceral pleura is the layer which is closer to the lung, and one more layer will be along the chest wall. All of you know it from the anatomy. So the gap between these two layers is called as, what is that? The gap is only called as, yes, the pleural cavity. We'll call it as a pleural cavity. Now, pleural cavity normally has a negative pressure. Negative pressure means it can suck anything inside. It can suck anything inside. So what will be there? There is a penetrating trauma will be there. If penetrating trauma will be there, penetrating trauma will pull all the air into the thoracic cavity. All the air will come inside because it has a negative pressure. Now what will happen? It will start to compress this lung. It will start to do what? Compress this lung. So now what happens? The lung would look something like this. Lung will look something like this. Now all this area will be filled with air. All this area will be filled with air. Now this air creates a pressure to push the mediastinum and other structure to the opposite side. To which side? To the opposite side. That is a clear cut. So if lung is not there, all this area is filled with only and only air. Air will look which color? Yes, black color. And most importantly, no vascular markings. It is clearly suggesting you what is that? Yes, that is suggestive of pneumothorax. Which is that? Pneumothorax. What is that? Pneumothorax. So this is the story of your pneumothorax and images related to the chest. So once we are done with that, I want to discuss with you people some images related to the abdomen as well. Let's bring them in. Okay. So these are the images which are related to normal plain X-rays, which are related to your which cavity, which area? GIT area. So let's talk about all these important images which are previously asked also. So let's talk about those, right? So when I'm speaking of this particularly this image, if you notice, so how many gas bubbles you can see? This is a child's abdominal X-ray. This is what? Abdominal X-ray of the child. On the abdominal X-ray of the child, if you notice here, there is one enlargement and black color is telling me what is there? Gas is filled. Okay, definitely we will share the notes, not a problem. Definitely we will share. I think orthopedics notes is already tagged with the description of the video link of orthopedics, I guess. Okay, you can just go check there. If that is not there also, I will make sure that is updated for you. Okay, now there is one bubble. Yes, very good. There is one more gear bubble and also one more here. So this is called as a triple bubble sign. We'll call it as a triple bubble sign. Okay, triple bubble sign. Triple bubble sign is suggestive of what is that? I'm not having any source to study. I can't afford this one. Definitely I will provide you. See, if one thing I'll make it very clear. Definitely I will provide, and most importantly I'll make sure that has been tagged along with the videos. I have requested our team. They're going to upload, and for orthopedics I have checked it. Please go and check the link that is available for you. Okay, so if you have that difficulty, do not worry. People like us do exist and we will help you. Okay, definitely, always. Okay, so please understand here triple bubble sign. This is a suggesting of jejunal obstruction. This is suggesting of jejunal obstruction. Jejunal obstruction. This is suggestive of what is that? Jejunal obstruction. Sir, how do you know it is jejunal obstruction? क्या नींद में पता चल गया तुम्हें? नहीं भैया, समझाता हूँ. उसके लिए भी reason is there. So what is there? You remember what is this? Your esophagus, followed by your stomach, followed by your duodenum, then you will get your jejunum. So if there is an obstruction somewhere in the jejunum, okay, if there is obstruction, all the food and air. So now you might be thinking, sir, we only eat food now, how did air enter into the GAT? ये भी बहुत सवाल आता है. Always remember, whenever you are swallowing food, you are also swallowing some air also with it, called as aerophagy. Okay, we'll call it as a aerophagy. Now air will keep on going inside little bit. Okay, वो कहीं पे भी घुस जाता है. Okay, so air will come inside and along with the food. Now first all the content will start to accumulate here. So jejunum will start to enlarge. Jejunum start to enlarge will create one bubble. Okay, jejunum's bubble is ready. Then Now what will happen after that? All the food and air will start to accumulate in the duodenum. Duodenum will also get enlarged. Here we go, duodenal bubble. Now stomach, after that stomach will also start to get enlarged. So that is suggesting me of here. So all the three bubbles were suggestive of what is that? That is your triple bubble sign. Okay, now let's get to the next important aspect. What is that? So this is a very interesting. So actually this is a chest x-ray, but since it is a GIT related disorder, I am doing with the images of GIT. That's it. Okay, फिर बाद में कोई बोलेगा अरे मारुति सर तो चेस्ट एक्सरे में ये करवाए नहीं थे भैया, मैं करवाए होगा, थोड़ा आगे पीछे किए. Okay, definitely we will do it. Now remember, this is a high powerful MCQ. To understand this, हम लोगों को एक छोटा सा theory पढ़ना होगा. Let's study about that, then we will understand. Now normally my dear students, what will happen is that during the development, during what development, esophagus will develop from up to down like this, and another part of the esophagus will be developing. So they both will be developing, means two blind ends will be, one will be coming down. Bhaiya mera jodi kahan hai? It will be searching for its partner and it will start to come down, and one more part will come up. Both of them will fuse. Later on they will become a esophagus like this. Okay, so this is the development. Okay, now this is the development, and there is one more structure also developing here. What is that? Your, yes, trachea is also developing. So between the trachea and esophagus, we have something called as a tracheoesophageal septum. So all this is occurring when you are in the mother's womb. During the development I am speaking, we will call it as tracheoesophageal septum. Tracheoesophageal septum. Now this tracheoesophageal septum, okay, tracheoesophageal septum, okay, this septum will have a posterior deviation, So if there is a posterior deviation of the tracheoesophageal septum, it will create what? So because of that, now imagine there was a septum which was present like this. Septum was just in front of the esophagus, right? Now this fellow has gone where? Into the side. So now what will happen? Will the esophagus completely form? ये तो नीचे से एक हिस्सा, one part was coming from down like this, one part was coming from up like this. Now both of them cannot fuse. So if both of them cannot fuse, that will create what is that? After birth, one esophagus will be, upper esophagus will be like this, lower esophagus will be like this, and we will call it as absence of formation of esophagus, called as esophageal atresia. Okay, what is esophageal atresia? Esophageal atresia is nothing but absence of esophagus formation. Now what will happen? Trachea will develop on its own. Yes, trachea will be fine. But what can happen? This upper esophagus can create what is that? Abnormal connection. Abnormal connection between the trachea and trachea and the esophagus. Abnormal connection is present between trachea and esophagus like this. We will call it as a tracheoesophageal fistula. Tracheoesophageal fistula. So tracheoesophageal fistula is that as a result of posterior deviation of tracheoesophageal septum. Posterior deviation of what? Tracheoesophageal septum. So this tracheoesophageal septum will have a posterior deviation. Because of that esophageal atresia will occur. So if esophageal atresia will occur, that will lead to what? So during this, what can happen is that, so all the salivary content can go into the trachea. All the salivary content, whenever baby swallows the saliva, that can go into the trachea, creating aspiration. Problem number one is aspiration can be present. Along with aspiration, now next important, so baby saliva is continuously produced. Immediately after the birth, saliva will be produced. That saliva baby has to swallow. Normally all of us swallow the saliva, right? Now when saliva comes, all the saliva, my dear students, will start to go into the esophagus, but saliva cannot pass through because absence of formation. If there is absence of formation, so what will happen? Pouring of saliva. Baby will have pouring of saliva. Continuously saliva will be coming out of the mouth. Because baby is not able to swallow the saliva. So continuous pouring of saliva and aspiration is possible with the tracheoesophageal fistula. Sir, why it is important for us? Now, when I notice these signs and when I notice this continuous pouring of saliva and all these things, I will think, okay, now there is some problem maybe with the esophagus. I want to confirm it. For that purpose, I will take one nasogastric tube, pass it from the nose, and that it will go into the esophagus, going further. But if normally child was normal, if you pass the tube would have gone all the way into stomach. But now what happened? Absence of, so tube tracheo, that is NG tube will come. NG tube comes and it will start to coil here. So coiling of NG tube. So if you can notice here, so this is not some chain the baby is wearing. It is actually NG tube. NG tube has coiled. We will call it as a coiling of NG tube. Coiling of NG tube. Coiling of NG tube suggestive of esophageal atresia. Suggestive of which disease? Esophageal atresia. Esophageal atresia. So this is also a previously asked question. Be very prepared about it. Okay. Now if you can notice this image, yes, this is also a very interesting image. Now here we can notice, so there is one bubble very clearly appreciable. There is one bubble which is present over here, and there is second gastric bubble. So this is only called as double bubble sign. We'll call it as a double bubble sign. We'll call it as what? Double bubble sign. So double bubble sign is telling you of which disease. Double bubble sign means, I told you people earlier, stomach and duodenum. So if there is an obstruction of duodenum, duodenum will start to enlarge. Okay. इसके बाद कौन सी टॉपिक कराएंगे यार? पहले तो हम जीआईटी का खत्म करवा देते. मैं पहले ऐसा सोच रहा हूँ कि आप लोगों का रेडियोलॉजी के लिए पहले कर देते, पहले पूरा अपना ये खत्म करें, एक्सरेस खत्म करते हैं. ठीक है. देन वी विल कम टू अल्ट्रासाउंड, देन वी विल डू द सिस्टमिक रेडियोलॉजी along with that CT and MRI. ठीक है जी. Alright, Kapil Chaudhary. Now let's look here. So if there is an obstruction in the duodenum, that will enlarge the duodenum, creating one bubble of our duodenum, and our stomach will also get enlarged, that is creating a other bubble. So two bubbles you can notice called as double bubble sign. So double bubble sign, my dear students, is seen with which disease? It is due to duodenal obstruction. Duodenal obstruction. Duodenal. अच्छा, कौन सी सब्जेक्ट होगी वो सब्जेक्ट का तो यार आपको अपडेट आता रहेगा शायद. राइट नाउ ऑलरेडी सम अदर गायनी वाज आल्सो गोइंग ऑन इन आवर चैनल. इसके बारे में मैं अपना टीम को बता देता हूँ कि मैं अपना टीम को रिक्वेस्ट करता हूँ कि अगले कौन सी क्लास आने वाले है उसका एक शेड्यूल बना के आप लोगों को यूट्यूब में ही डाल दिया जाए. ऐसा कुछ मैं अपना टीम से बात करता हूँ. ठीक है जी. नाउ लुक हियर, duodenal obstruction. Duodenal obstruction. So duodenal obstruction is usually caused by two important diseases. Remember, one is your very important called as duodenal atresia. So how esophageal atresia occurred? Absence of formation, like that only duodenal atresia. Okay. Along with that, one more condition is there, annular pancreas. So annular pancreas and duodenal atresia are two important conditions which will create a double bubble sign. Okay. So here you can notice very clearly. Okay. बिल्कुल कर देंगे, no problem. See, we'll always anytime we take up the classes for your NCA preparation, मैं बहुत कम बात करता हूँ इसके बारे में. Let's talk about it right now. ठीक है सर. बहुत सारे लोग मतलब since we are speaking about the मतलब ऐसे ही आ गए तो मुझे मन में आ गए तो बता रहा हूँ. तो यार आप लोगों ने ना, whenever you are preparing, there are so many times आप डर के मारे आधा पढ़ना छोड़ देते हो. By getting scared, you are leaving out the half of the topic. यार कभी ये सोच के like you know you are thinking that oh my god होगा कि नहीं होगा. यार तुम कहीं बाहर जाके बिरयानी खाओगे ना, वहां से डायरिया भी हो सकता है, पर उसके लिए सोचते नहीं. वो बिरयानी है, चलो खा लेते, देखा जाएगा. फिर एग्जाम के लिए क्यों ये नहीं सोचते? एग्जाम के लिए भी तो सेम माइंडसेट रहना चाहिए ना. एग्जाम दिए तो अब देखा जाएगा जो होगा. तो एग्जाम देने का टाइम पे डरना नहीं. मतलब पूरे ऐसा भी नहीं है कि पूरा डर नहीं, थोड़ा बहुत तो रहना चाहिए. आई एम नॉट सेइंग नो फॉर दैट, बट रिमेंबर बीइंग स्केयर एंड बाय नॉट स्टडी. और एक गलत करते हैं सब लोग. सर मैं 10 सब्जेक्ट रैपिड रिवीजन करके चला जाऊं. भाई 19 सब्जेक्ट का प्लीज डू नॉट डू द रैपिड रिवीजन एंड गो. हम लोग बैठे ना यहाँ पे पढ़ाने के लिए. We are here to teach you people. So study the whole content and go. You're not supposed to go in the exam hall later tell that we didn't get our question. See, the exam is very easy. Okay, very easy means we are approaching it wrong. That is the mistake. हमेशा एग्जाम के लिए देखो, एग्जाम इज इजी, देर आर कंटेंट्स टॉपिक्स. मैं ये नहीं बोल रहा हूँ कि 19 सब्जेक्ट का पूरा टेक्स्ट बुक पढ़ो. सो व्हाट एवर द नोट्स एंड टॉपिक्स वी टीच, दोस टॉपिक्स वर प्रीवियसली आस्क्ड, प्रीवियसली टेस्टेड, दैट मींस दे आर इंपॉर्टेंट. सो यू नीड टू फोकस ऑन दिस. ओके, हम लोग जो कंटेंट देते हैं उसको पढ़ो, रिपीट 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 रिपीट. ओके, सो रिपीट 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 द कंटेंट. मतलब एक बार नोट्स पढ़ लिया, दूसरा इमीडिएटली नहीं जाना है कि मुझे 100 के 100 मार्क आ जाना चाहिए. इमीडिएटली व्हाट यू नीड टू सपोज टू डू, practice few question, repeat the notes again, practice few question. So the repetition will help you. Okay, and never underestimate yourself. सब हो सकता है यार. You went out of this country for studying at the age of 17 and 18 years and you survived everything and came back. One exam you can't do. इतना weak हो गए तुम, right? See, this is bad luck. ये 140 के पास में जो फेल होते हैं ना, इन लोगों को प्रिपरेशन की कमी नहीं होती. ओके, ऑल राइट. चलो करते हैं यार, क्वेश्चन भी करवा देंगे. एग्जाम पास आएगा तो क्वेश्चन तुम जो सब्जेक्ट पूछो सब करवा देंगे, इसमें कोई दिक्कत नहीं. ठीक है, आप लोगों को भी और भी मतलब लगता है कि सर हमें क्वेश्चंस और ये वो चाहिए, तो अपना ऐप तो है ही, डाउनलोड कर लो मेडुहब. ठीक है, चलिए कंटिन्यू करते हैं. लेट्स कम बैक टू आवर रेडियोलॉजी. नाउ हियर आल्सो वी हैव, व्हाट इज दैट माय डियर स्टूडेंट्स, हियर वी हैव मल्टीपल enlarged bubbles are seen. Okay, but if you notice in few bubbles, what is there is lot of air is present. But if you notice here in this bubble, there is small amount of fluid also present. All this red one I'm putting dots is fluid, right? So this we will call it as multiple bubble sign, are called as multiple air fluid levels. Multiple air fluid levels. So multiple air fluid levels is suggesting you of intestinal obstruction. But which intestine? That is your small intestinal obstruction. Okay, so this is your small intestinal obstruction. So here also again we have multiple air fluid levels. This is also suggestive of what is that? Small intestinal obstruction. All right, let's go to the next important. We'll talk about that image later on. Here I wanted to discuss one thing. So I want you people to pay your attention, a lot of attention, and very important question. So this is your left part, this is your right part. Under the right dome, what is there? You can notice, see, this is your diaphragm. Below the diaphragm you can notice some air, but on which side? On the right side. So left dome, if the air is there, see, air under which dome? Under the left dome. Is normal, but here we call it as a gas under diaphragm. That is suggesting you of that is called as diaphragm. So gas under diaphragm or air under diaphragm. Under which diaphragm? Yes, right dome. Gas under right dome of the diaphragm. Under which dome? Right dome of the diaphragm. That is suggesting you there is, what is that called as? Pneumoperitoneum. What is that? Pneumoperitoneum means there is a air inside the peritoneum. So if there is a air in the peritoneum, that is suggesting you of there is some perforation in the GIT. That might be perforation in the duodenum, or it can be perforation in the elsewhere. But if air under the diaphragm, that is clearly telling you what is that? It is a pneumoperitoneum. That is a sign of perforation. In the GIT. Very, very important and very frequently asked question. So if there is peptic ulcer, if there is some ulcer in any other part, that can lead to rupture of the intestines, creating what is that? Air under the diaphragm. So here also we have one more image, that is your single bubble sign. There is only one bubble, single bubble sign. Single bubble sign is suggesting you of what is that? Yes, single bubble sign is suggesting you of congenital hypertrophic pyloric stenosis, or also one more possibility, gastric outlet obstruction. Clear? So this is a story of your single bubble sign and few important non-contrast images inside your, what is that? In the GIT side and as well as your your chest exercise, right? So with this much being said, let's take a small break and we will continue later. Okay, let's take a small break. All right, let's continue. So far we discussed about non-contrast images in the GIT, which were very important for our FMGE exam, which was previously asked. Now let's talk about what is that next group of images. What is that next group of images which are about the contrast related images. Okay. So let's talk about that. Let me check about. Okay, perfect. Audio, video, everything is clear. Let's start the discussion. Okay. Now it's very simple, my dear students. What exactly I'm trying to explain to people? So we are using a contrast, like I told you, barium swallow. Barium swallow is done for what? I told you people for the esophagus. For which organ? Esophagus. So we have some barium swallow images. Let's look at them and understand the diseases. Not just the barium swallow, but also I have other images also which I want to discuss with you people. Okay. Now, after the barium, if you can notice here, my dear students, what is happening? What is happening? So, a patient has swallowed the barium. Now, if you notice, upper part of the esophagus, all this area of the esophagus, if you notice, it has been enlarged. Okay, so enlarged esophagus. So, upper mega esophagus, we call it as a mega esophagus. We call it as a mega esophagus. But if you notice in the down part, see, esophagus has narrowed itself or contracted itself. So it is creating something called as bird beak appearance, called as bird beak appearance. We call it as a bird beak appearance. If you can notice, as if it is a beak of the bird, it is looking like that. So this bird beak appearance are also called as pencil tip appearance. What is that called as? Pencil tip appearance. This is exclusively seen with the achalasia cardia. What is that? Achalasia cardia. What is achalasia cardia? So achalasia cardia is a condition where there is, what is happening, you need to understand, the lower esophageal sphincter is undergoing contraction. So lower esophageal sphincter has gone into, what is that? Contraction. Spasm of lower esophageal sphincter. Okay, so because of lower esophageal sphincter, the patient is not able to swallow anything. All the contents will remain in the upper part only. So the patient will have dysphagia. What is that? Dysphagia. So dysphagia, very, very important. Initially to liquids. Initially to liquids. Okay, initially to what is that? Initially for the liquids. So dysphagia to liquids, later for the solids also, later for solids. So what do I mean by this? Very simple. Solid food, if this person swallows, he will not be able to swallow later on, but initially dysphagia only for difficulty in swallowing, only for the liquids. We will call it as achalasia cardia. Dysphagia to liquids, later for solids, and most importantly Burbic appearance or a pencil tip appearance, and mega esophagus in the upper part, we will call it as, yes, very important appearance. What do we call it as? Mega esophagus in a achalasia cardia. Okay, so this is a normal image of what is that? Yes, barium meal. We'll call it as a barium meal. Okay, now you give the barium meal in the form of a solid. The person has swallowed the barium. Person has swallowed the barium. So if they swallowed the barium, immediately if you take a X-ray imaging and look here, you can look at the stomach. But after some time, from the stomach that has gone into all the intestines, we will call it as a barium meal. Barium meal follow through, because all of you know food will remain in very good stomach for 3 to 4 hours. Later only it will go into the intestine. So if you look at the intestines using barium swallow, we will call it as a barium meal follow through. Now this one is a very, very interesting image. What is happening? First and most important, look here, there is some cannulation is seen around, what is, into the rectum. From the rectum I'm pushing the contrast, so this will be called as barium enema. This will be called as a barium enema. So in the barium enema, my dear students, if you notice, so in this area, all this area, what has happened, it is looking like this, something like this, right? It is looking something like, so we call it as sawtooth appearance. Sawtooth appearance. This also seen in which one? In the ECG also. Okay, that is with the atrial fibrillation. Okay, sawtooth appearance. And here also, if you notice, multiple out pouches are occurring. We will call it as multiple out pouches and sawtooth appearance. We will call it as very important, very important, diverticulosis of the colon. What is it called as? Diverticulosis of the colon. Diverticulosis of the colon. Okay. Now here is a very interesting, this is also a first and most importantly, it is a X-ray. Of course it is a X-ray. Now with contrast or without contrast will be our next question. Yes, it is with the contrast. If it is with the contrast, the question for us is which area. Of course we are looking at the esophagus. And what is the contrast we use for esophagus? Very good, my dear students, that is your barium. So in the barium, if you notice, in this particular area, okay, and here also in this area, right, and in this area, what is happening? Contrast is not going. The area where contrast is not going, we will call it as filling defect. We call it as a filling defect. We'll call it as what? Filling defect. So filling defect creating a, so if you notice here, it is creating a rat tail appearance. We'll call it as a rat tail appearance. So this rat tail appearance and also your, what is that? That is filling defect is suggestive of esophageal cancer. Remember, esophageal cancer. Okay, so why this there filling defect? All this area is already tumor growth has occurred. That tumor growth is there, because of that contrast could not enter inside. So very clearly it is telling you esophageal cancer. So that is the story of your esophageal cancer. Now in this image, if you notice, I have given a barium contrast. So normally if I give a barium contrast and take the images, fine. But in the cases of if the suspected of perforation, if there is a suspected case of perforation, so please remember, so contraindication for barium. It is a contraindication for barium. It is a contraindication for barium. So you are not supposed to use the barium, because barium is a irritant which can cause, if barium is used, because barium can cause contrast mediastinitis. What is that called as? Contrast mediastinitis. Contrast mediastinitis is the major complication associated with, what is that? Barium. So we are not supposed to use it in the cases of, yes, very importantly, that is your very importantly perforated case. So in the perforation, better contrast. So further, if there is a suspicion of perforation, we use something called as gastrographin. Or also we can use a urographin. Basically majorly used one is gastrographin. If that is not there, then we can also use iohexol. Now if you notice here, so contrast has been given, and the contrast, if you notice, somewhere it is leaking. Contrast is leaking. That is telling me that is esophageal perforation. Because contrast is leaking out of the esophagus. Okay, so this is the story of your, what is that? Contrast is leaking, that is esophageal perforation. Let's go to the next image. Let's look here. So this is also again a X-ray with, what is that? Of course, barium contrast is there. Barium is used. Now in the barium, if you notice here, there is one outpouching. There is one small pouch which has formed here. So this pouch here, we call it as, my dear students, Junker diverticula. We will call it as a Junker's diverticula. So Junker's diverticula is a condition where there is a diverticular formation which is occurring as a result of esophagus outpouching. This esophagus outpouching will occur from a weak muscular area called as the Killian's dehiscence. We'll call it as a Killian's dehiscence. From the Killian's dehiscence, if it is coming out, we will call it as a Junker diverticulum. We'll call it as what? Junker diverticula. So Junker diverticula is the condition. What will be there? There is a outpouching of esophagus which will look something like this. In Junker's diverticula, we find a named sign called as Boy's sign. We call it as a Boy's sign. Okay, so that is your Junker's diverticula. Now here this is a barium enema, but if you notice here, my dear students, there is one appearance which is seen. So this one is only called as claw sign. Claw sign is clearly seen with something called as intussusception. Okay, into susception. So into susception, what will occur? So one part of the intestine will go. So intestine is a pipe like this, right? Intestine is a straight pipe. Instead of that, intestine, one part of the intestine will go into the another part of the intestine. So intestine will come into the another part of the intestine. We call it as invagination of intestine. So if there is an invagination of intestine, it is suggesting you of what is that? Into susception with the help of a sign called as claw sign. This is a previously asked question. Remember, claw sign is seen where. Okay. Let's get to the next important. Again, we already discussed this. This is a diverticulosis of the colon. Then, my dear students, this is what? So, this is actually a little bit, what to tell? It is a invasive, not little bit, very invasive procedure. What is this invasive procedure called as ERCP? What is that? ERCP. Where do we use ERCP? ERCP is used for visualization of remember your biliary tree. Visualization of which one? Biliary tree. For the biliary tree visualization, we require what is that? Yes, we require a ERCP. What is ERCP? Is called as endoscopic endoscopic retrograde endoscopic retrograde cholangiopancreaticography. Cholangiopancreaticography. Okay, so what is this ERCP? What we are going to do is that we will take one endoscope. Special endoscope is used because normally endoscope will have a camera in the front, so tip will have a camera. But ERCP endoscope will have a camera on the tip also, on the side also. Why on the side? Remember, all of you know this. What is this? This is your esophagus, stomach and duodenum, right? So now what will happen is that here you have your liver. From the liver, what is coming out? Bile ducts are coming out. They're combined with a cystic duct and it will create a common bile duct, So this common bile duct will pass behind the duodenum, right? Anatomy, you know. So it will come and go inside your, what is that? Go into your, very importantly, what is that? Duodenum at a sphincter of Ardite, and from here we will have our pancreatic duct come. Right, so we will take our endoscope, go into the stomach. From there, go to duodenum, go to this area. We will open the sphincter and inject some contrast into the biliary tree. So once we inject the contrast into the biliary tree, the contrast will go into the pancreatic duct also, and contrast will go into the common bile duct also. After that, if I take a image, what will happen is, very importantly, image will tell you the visualization of how well is your pancreatic and bile duct are there. So now here, remember, this is the ERCP image. In the ERCP image, you can notice, so this particular center one is your endoscope, right? So here is your, what is that? Yes, your common bile duct. This common bile duct is combining with, what is that? Very important, pancreatic duct. So in the ERCP, you always remember as a technique. So wherever the endoscope is there, this is the endoscope. Anything on the right side of the endoscope, usually that is your hepatic ducts, and your, what is that? That will be your very important common bile duct. And here, my dear student, anything on the left side usually suggestive of, what is that? Pancreatic duct. So when you do a ERCP, in the ERCP, if you can notice here, so pancreatic duct has been enlarged. Oh my God. And also you can notice solid calcifications here. This is suggesting you of chronic pancreatitis. So chronic pancreatitis, this appearance is only called as a chain of legs appearance. What is that? Chain of legs appearance. This chain of legs appearance occurs as a result of what? Occurs as a result of chronic inflammation, chronic pancreatitis. And if there is a chronic inflammation, that will create a chain of legs appearance. Okay, then here also we have one more interesting image. So this is a ultrasound. It is creating a target like sign. We'll call it as a target sign. The target sign is, once again, yes, the target sign is seen with into susception. Target sign is seen with which disease? Into susception. And here also again we have bird beak appearance. Bird beak appearance is seen with, yes, already we discussed. What is that? that is only called as your achillesia cardia. Now here, my dear students, so this is a very, very important image to understand. Please look here. So this appearance, we will call it as lead pipe appearance. We call it as a lead pipe appearance. Okay, so what is this lead pipe appearance is seen with so lead pipe appearance, it is exclusively visible on the large intestine. So this lead pipe appearance in the large intestine is suggestive of ulcerative colitis. Ulcerative colitis. Okay, now you can ask me, sir, why not in Crohn's disease? Remember, Crohn's disease is not a continuous disease, means so it can involve any part of the GIT, but it involves complete all the length of the GIT. No, some part of the ileum will be involved, some part of large intestine will be involved, some part of rectum will be involved, but ulcerative colitis involves only large intestine. It is a inflammatory bowel disorder which involves only the large intestine, and this large intestine will have, what is that? Yes, this will have a continuous lesion. So continuous lesion, that is why completely you can see what is that lead pipe appearance. So what is that lead pipe appearance? So this is the story of your all the GIT radiology. Okay. So with this much being said, so as we planned the content, actually I had planned it for longer, but we were able to finish it early. So because of that, we'll conclude the class here for today. In the next class, I'll continue the rest of the video. Thank you. See you people.